In this video, we are going to learn about the respiratory volumes and the spirometry. How do we assess ventilation, or how do we assess the functioning of a lung? How good a lung is performing its function? We have certain respiratory volumes and we have respiratory capacities. These respiratory volumes and these respiratory capacities, they can be used to assess the respiratory status. And volumes, they are smaller compared to the capacities. When one or two or more volumes, they come together, two or more volumes come together, they make a capacity. And respiratory volumes and capacities, they are abnormal in people with pulmonary disorders. So this is how we can detect it. And the instrument which is used to assess ventilation is known as spirometer. And now this spirometer has also evolved, and there are many electronic measuring devices which are used today. There are four volumes. First of all is the tidal volume. Tidal volume is the amount of air which moves into and out of the lung with each breath. And it is around 500 milliliters. So right now, me and you, we are sitting and rest, and the amount of air which is going in and coming out, it is tidal volume without any effort at rest, normally like we're breathing. So with each inspiration, I'm taking 500 ml inside, and with each expiration, I'm taking out 500 ml. Then we have inspiratory reserve volume. It is the amount of air that can be inspired forcefully beyond the tidal volume. So the first 500 ml is the tidal volume, and then the air which I can take in after 500 ml, that is the inspiratory reserve volume. So now let's take a deep breath. So the amount of air which has gone in, the first one is, we will say, is the 500 ml of tidal volume, and then the other is the inspiratory reserve volume, which is about 2100 to 3200 ml depending upon everyone's size. All right, and then there is expiratory reserve volume. Expiratory reserve volume is the amount of air that can be forcefully expelled from the lungs after the tidal volume. So we will also, this is the tidal volume. Then after the tidal volume, there is expiratory reserve volume. Then there is residual volume. This is the amount of the air which always stays in the lungs, because this is the air which keeps the alveoli inflated. It is always present in the lungs. These volumes, they combine and make capacities. Now we have inspiratory capacity, which is represented by IC. This is how it is written, and it is the sum of tidal volume and the inspiratory reserve volume. Then we have functional residual capacity, FRC. It is the sum of residual volume and the expiratory reserve volume. Then we have vital capacity. Vital capacity is the sum of tidal volume, inspiratory reserve volume, expiratory reserve volume. And then the total lung capacity, it will contain all these, all of this. So it is sum of all the lung volumes: tidal volume, inspiratory reserve volume, expiratory reserve volume, and the residual volume. Let's go over this together. Now I want you to be attentive, because it will really help you. So this is tidal volume. This is the normal air of breath in this light blue strip. This represents the tidal volume. This is 500 ml. This is the air which is going inside my lungs and coming outside of my lungs at rest. It is equal to 500 ml. And then this, starting from this point to this. This is the inspiratory reserve volume. This is the air I can take in addition to the tidal volume. So when I take a deep breath, this is the volume I can take in on top of the tidal volume. Its value is around 3100 ml. And then we have expiratory reserve volume. Expiratory reserve volume is from here to here. So this is the amount of air I can expire from my lungs after the tidal volume, and its value is 1200 ml. And then there is this green strip. This is the residual volume. See, this volume, it never leaves the lung. It is always going to stay in the lung, because this is responsible for the inflation of the alveolar sacs of the alveoli. Okay, so now we are done with the volumes. These are four of our volumes. tidal volume, and inspiratory reserve volume, expiratory reserve volume, and the residual volume. Now we have capacities. Capacities, when two or more volumes come together, they make a capacity. So first of all, we have inspiratory capacity. Inspiratory capacity, it is the tidal volume plus the inspiratory reserve volume. Right? Then we have functional residual capacity, FRC. This is the expiratory reserve volume and the residual volume. Okay. Then we have vital capacity. Vital capacity, it contains inspiratory reserve volume, tidal volume, and expiratory reserve volume. So this is vital capacity. Then we have total lung capacity. So total lung capacity is all of this. It contains all the four volumes: inspiratory reserve volume, tidal volume, expiratory reserve volume, and the residual volume. This table, it summarizes everything we went over. You can go over this table and it can be a good source to learn all of these together. In the respiratory system, there is also a space which is dead space. What is dead space? Anatomical dead space, it does not contribute to the gas exchange, and it consists of the air that remains in the passageways, and it is about 150 ml. So out of 500 ml of tidal volume, if tidal volume is 500 ml, this is the amount of air I am inspiring with each breath. 150 ml, it stays in the passageways and it never goes to the gas exchange area. So this is known as anatomical dead space. Anatomical dead space, it is the portion from the nose till the terminal bronchiole. So this whole passage, it is not involved in the gas exchange. So the air in this passage, it is known as to be present in the dead space. Then we also have alveolar dead space. What is alveolar dead space? Some of the alveoli, they can be collapsed or they can be obstructed due to mucus. So they are not participating in the gas exchange. So this is also dead space. Total dead space is the sum of the anatomical dead space and the alveolar dead space. Now let's go over the pulmonary function tests. The pulmonary function test, they tell us that how good the lung is doing its function of ventilation. So spirometry is the process which we use, and it can distinguish between the obstructive pulmonary disease. So there is a group of diseases which are known as obstructive pulmonary disease, and then there is another group of diseases which is known as restrictive diseases. So in obstructive pulmonary diseases, there is increased airway resistance, right? We said that under normal conditions, the resistance does not play a very big role. But when someone has a disease, the resistance does become significant. So in obstructive pulmonary disease, what is the defect? There is increased airway resistance. For example, in bronchitis, itis means inflammation. It means there is inflammation in the bronchitis. And what happens in these diseases? Usually they are chronic, so we call them COPD. You will, at many times you will read the term COPD. That means chronic obstructive pulmonary disease. And what happens in these diseases, that all the capacities and the volumes, they may be increased because of hyperinflation of the lungs. So the total lung capacity, FRC, RV, they are all increased because there is hyperinflation. Then the other group of diseases is the restrictive diseases. In restrictive diseases, there is reduced total lung capacity due to the disease. For example, tuberculosis, or it can be due to some reason there is fibrosis in the lung. So in a way, the lung is not restricted. It is not expanding as it should. The lung compliance has decreased. Too much air is not going inside the lung. As a result, these vital capacity, total lung capacity, FRC, RV, they are declined because lung expansion is compromised. To give you a hint how to differentiate between these diseases, so in obstructive diseases, there is obstruction to outflow. Okay, you can remember obstruction is starting with O, then outflow is also O. So in obstructive diseases, there is obstruction to outflow of air. So if the air cannot go out, then what will happen? The lung will hyperinflate. It will stay in the lung. So we have air trapped inside the lung, and the volumes and the capacities, they are increased. So this TLC, FRC, RV, they are increased because of trapped air inside the lung. So, and in restrictive diseases, there is restriction to inflow of the lung. The air, it cannot go inside the lung because there is fibrosis, there is tuberculosis. The lung, it is not compliant. It does not want to take the air in. So as a result, these capacities and volumes, they are decreased. Pulmonary function tests, they tell us if the disease is obstructive or restrictive. How do we interpret the pulmonary function test? Let's see. So there is a term forced vital capacity. What is forced vital capacity? It is the amount of gas forcibly expelled after taking a deep breath. Okay, let's try it. Everyone take a deep breath and then expire. So this is the amount of air you expired. It is known as forced vital capacity. And then there is forced expiratory volume. So it is a portion of the forced vital capacity which is expired in a certain time. And we noticed, we note down FEV1. What is FEV1? It is the forced expiratory volume in 1 second. So how do we do this test? The patient is given a spirometer and the patient is told to take a deep breath and then expire forcefully, and then it is attached to a computer or to some machine, and a graph is made, and we see how much air the patient expired in the first second. So what happens that in healthy individuals, they can expel 80% of the forced vital capacity in 1 second. Okay, so they expel 80%. And then patients with obstructive disease, they exhale less than 80% in 1 second. Why? Because in obstructive disease, there is obstruction to the outflow. So in 1 second, less than 80% is expelled. Whereas those with restrictive disease, they exhale 80% or even more than 80%. Even with reduced forced vital capacity compared to the normal, they have reduced forced vital capacity, but most of it they exhale in the first second because lungs, they don't want to keep the air in. So this is how we differentiate between the obstructive pulmonary disease and the restrictive pulmonary disease. Now there is a term alveolar ventilation. What is alveolar ventilation? So let's see. So the minute ventilation, it is the total amount of gas that flows into or out of respiratory tract in 1 minute. Normal at rest is 6 liters per minute, 500 ml per breath multiplied by 12 breaths per minute. So it comes to be 600 liters per minute, and it increases in exercise up to 200 liters per minute. And it gives a rough estimate of the respiratory efficiency. Then there is another term which is alveolar ventilation rate. It is the flow of the gases into and out of the alveoli during a particular time. So it is better indicator of effective ventilation. Now let's see alveolar ventilation rate. It takes into account the amount of the dead space, tidal volume, and the rate of the breathing. It can be calculated by this formula. Alveolar ventilation rate is equal to frequency of the breaths per minute into tidal volume minus dead space. So if we put in the values, we come to 4200 ml per minute. Because dead space in an individual is normally constant, AVR is affected by the tidal volume and frequency. And significant increase in AVR are brought about by increasing the tidal volume rather than the frequency. So tidal volume, it plays a more important role. Rapid shallow breathing can actually decrease AVR. Let's see this chart so it becomes more. So our alveolar ventilation rate, it is equal to the breathing per minute into tidal volume minus dead space. So we can see that our dead space, it is a constant in a person, right? So it is 150 ml. Now we are left with tidal volume and the frequency of the breathing. So we said that that tidal volume, it is more important in AVR compared to the frequency of the breathing. In fact, sometimes very rapid breathing can actually uh, decrease the AVR. How does that happen? Because when someone is breathing too rapidly, they are taking shallow breaths. So let's look at these calculation, it will make things clear. So under normal condition, the normal rate, so I will ignore this dead space. So the normal rate is 20 per minute and tidal volume is 500. So the respiratory rate 20 per minute, we are taking a big number, so it comes to be 7000 ml per minute. Okay, so this is normally in normal conditions. So now if someone is taking slow deep breathing, slow deep breaths, so it means the respiratory rate is decreased. This is 10 per minute, and then the tidal volume has increased because deep breathing, that person is inspiring and expiring more than the tidal volume. So let's take this value to be 1000 and it comes to be 8500 ml per minute, the AVR. Now let's increase the respiratory rate. So someone whose breathing rate is very high, for example 40 per minute, and now the tidal volume has decreased. Why? Because that person is, because of rapid breathing, he's not taking too much air inside. So now we get 4000. So you can, as you can see, that if the respiratory rate is increased too much, because the tidal volume it is decreased, the AVR it actually decreases. So tidal volume it affects us the most. It is important to take normal amount of tidal volume or increased amount of tidal volume if we want to have a AVR value increased.